So I've been tasked with reviewing systemic therapy for lung cancer in about 20, 25 minutes. So this will be a relatively short talk, not too much detail, but I'll leave some time for questions. And here we go. So yes, I do believe that robots can do anything, and so oftentimes I ask Netu if we could resect it with the robot, but not sure if that will have any effect on when you have metastases with lymph nodes. Okay, so here are my disclosures. So I'm going to spend the first part of this talking about how we treat metastatic lung cancer and then try to bring it back to the adjuvant setting, and both the neoadjuvant and adjuvant, which is probably more relevant for this group. And as you'll see, we're much further behind in the early stage setting, which is potentially the most curable. So shown here is an old slide that I haven't updated recently, but what we can see is the median survival of non-small cell lung cancer over the decades. And we really haven't made much progress until about this century. And even now, the median survival is starting to increase slowly. But what the big difference is, and I think the big excitement in thoracic oncology is not this median number, but the number of patients that are now alive at 2, 3 years and beyond. I have several patients that are 6 years out with their metastatic disease, and that's really due to two factors. One, the advent of targeted therapies, which came along really around 2010, although the studies were done before that, and then more recently, the advent of immunotherapy in lung cancer. And so really what this has increased kind of our long-term survivors. We're not sure if we're really curing these patients, but we are having patients that are living a lot longer at this point. And so I'll start with a case. So we have a 58-year-old, 4-month history of chronic cough, and of course, 6 months history of the recurrent right middle lobe pneumonia, which is always a board's question on medicine, like why do they have right middle lobe pneumonia? She got several rounds of antibiotics, of course. She's coughing up some blood. She smoked 2 packs a day, but quit 7 years ago. She's mildly fatigued, but continues to work as a lawyer. She got a chest X-ray, which showed a right middle lobe opacity, which really would be a mass, and then was confirmed to be a 6-centimeter right middle lobe mass with bulky mediastinal adenopathy, 2-centimeter adrenal nodule, and 4-centimeter isolated liver nodule, active by PET scan, and this was confirmed to be an adenocarcinoma, and the brain was negative at this point. And so when this patient walks into our clinic, the first thing that we're looking at is the histology, as we'll get into a little bit. So this is an adenocarcinoma, and obviously we know this by the TTF1 and this, the lack of squamous markers, as well as lack of neuroendocrine markers. And so this is up to date. This is kind of our standard testing that anyone that comes in gets, usually in stage 3 and stage 4 settings. Sometimes early cases will slide in there, especially since we have trials for them now. But in general, we'll do several tests. One is in situ hybridization, or FISH, or fluorescent in situ hybridization, for a couple rearrangements, ALK, MET, ROS1, RET, and NTRK1, and that's because these all have either FDA-approved drugs or drugs that we can essentially get off-label to use for these. We then do molecular testing. Shown here is 4 of the genes that we test for. This is what's reported out. We actually test for about 50, and if you ask the pathologist or the molecular path lab, they'll actually give you the other genes, which may have some influence on how these patients will do. So BRAF, KRAS, EGFR, and MET. And then we do IHC for ALK, which actually has been shown to actually be better than FISH or equivalent, and then PD-L1. And so this patient actually ended up having an ALK rearrangement. And so they were positive both by the FISH assay, which is a break-apart assay, as well as IHC. And so these patients can do dramatically well. So the average progression-free survival for these patients in metastatic setting is about 3 years with alectinib. So that's their first-line therapy. And then there are several drugs after they progress on this. So this is one of the real success stories. It started with EGFR, so soon afterward we had ALK. But patients that can get targeted therapy can live a lot longer even in the metastatic setting. And so we look very hard for these, and tissue really is the issue. We always try to get a good biopsy, and sometimes we go back multiple times. If we can't get a good tissue-based biopsy, we'll often do blood-based biopsies. So if someone walks into my clinic today, and it may be a little lower in Pittsburgh because we have a little more KRAS mutations than other places, but about 30 or 35% of the time, a person with an adenocarcinoma of the lung, again, it's more common in never smokers, but you find more of these mutations in smokers because there's more of them, will find a targetable alteration, see either EGFR, BRAF, MET, ALK, some rarer ones, ROS1, RET, and NTRK1, and also maybe potentially HER2 mutation. So we have a growing number of targetable alterations, and these patients can do quite well. The response rate's about 70 to 80%. The average progression-free survival can be a year, 2 years, 3 years in some cases, and their overall survival is longer. So this is kind of one of the determining factors that we use in the metastatic setting. The other major advance I talked about, and you've probably seen this slide in a number of talks, is the advent of immunotherapy. And so it was thought for a long time that lung was not a very immunogenic tumor, although it had high tumor mutation burden. There was a very sad stage 3 trial in stage 3 setting with a MUC1 vaccine that was negative, which we won't get into, but it was essentially positive in patients that got definitive chemo-rads, and patients who were in Eastern Europe who got sequential therapy were negative. But then along came two kind of molecules, or two targets. One is this CTL4, which is present on T cells. And it was shown actually that antibodies that inhibit this interaction with dendritic cells or APC cells or the tumor would actually increase T cell activation. Although this happens in the periphery, and this is associated both in mice and men with high rates of autoimmune disease. In addition, there's a second checkpoint that's been approved, the PD-1 and PD-L1, and they've blocked antibodies against both. Theoretically, there are differences of what, if you block, for example, PD-1, you can actually still have other actions with PD-L2 or PD-2 and PD-L1 that are intact. However, practically, despite either blocking this or blocking this clinically, we haven't seen a difference in the results. So we essentially consider these equivalent, although there are different indications depending for these different antibodies. And the excitement around this was the fact that these were the first agents that actually worked in patients who didn't have targetable alterations. Smokers seemed to do better. The patients who seemed to do worse actually seemed to do better with immunotherapy. And so there was a lot of excitement about it. And this led to these approvals initially as single agent. And actually, this is in the adenocarcinoma setting with nivolumab versus docetaxel. And what you can see is that what was really exciting is not really the median, but really this tail of the curve. So we have patients that are out, again, I had a lady that just died of natural causes. She was out 6 years with her disease. She's the one lady who actually had a flare. She's the one patient I've taken off of hospice. I've only taken off in 6 years, taken one person off of hospice, and that was this lady. She had a flare. She had esophageal nodes around her stomach. She couldn't eat, didn't want a PEG tube, went home, and 2 weeks later she's eating full meals. And so she's one of these people she wasn't in this study, but she's one of these people at the end of the tail of this curve. So the excitement about immunotherapy is when it works, which is about 20% of the time, patients can have durable responses. And we can't yet call this a cure, but these patients are long-term non-responders at least. Now in the metastatic setting, we've moved to really combining this with chemo. So initially there was a lot of concern that combining chemotherapy and immunotherapy wouldn't work because the chemotherapy might kill the immune cells. Plus you're giving steroids with a lot of these regimens. But surprisingly, these patients do a lot better. So the response rate goes from about 30% to 50%. And there is definitely an overall and progression-free survival benefit with these patients. It seems to benefit all subgroups, especially subgroups that didn't really benefit before, including never smokers, although the numbers are small. And in other combinations, here I'm showing the carboplatin, pemetrexed, and Keytruda combination. Other combinations have showed potential benefit for EGFR and ALK, which prior to that really had no benefit at all to monotherapy. In fact, when my EGFR mutant patients asked for immunotherapy, I quote them quite reliably the response rate of 2.5% when given alone. So it's probably 7th or 8th line for an EGFR mutant patient. They all want immunotherapy, but it really does not work for them. However, it may work with chemo, and so that's another consideration. So kind of the standard of care now is to give our best drugs up front. So kind of just in kind of an overview of in the metastatic setting before we move to the adjuvant setting. So, we have these patients that come in with non-small cell lung cancer. We clearly care about their histology and then also their molecular drivers. So for the molecular drivers, if they have an EGFR, an ALK, a BRAF, or a ROS1, the standard of care is targeted therapy first. These are the same group of patients that if you give PD-L1/2 as monotherapy, which we'll get to on the other side, will not respond. So these patients often will ask about immunotherapy, and I'll be like, that's a really bad idea. For those who do not have a targetable alteration, we then do use PD-L1 status. If it's greater than 50% and they have a relatively low burden of disease, they can actually get treated with pembrolizumab alone. If they have a high disease burden or less than 50%, then based on histology, and really the standard of care, regardless of histology, although the platinum doublet's different, is this chemo-immunotherapy combination. So this has greatly kind of improved at least our 1 to 2 year survival rates at this point. So try to bring this into something that's more relevant. So what do we do for the patients who are actually the most curable? As you guys have seen this is just the update from the 8th edition for staging. As you know, as we go up in stage, our 5-year survival rapidly goes down. We're about 50% when we get to stage 2. And this is obviously with the best surgery and adjuvant therapy we have. And so the issue with this is, and this is old data but hasn't changed, is that as a tumor gets larger or you start having nodes, your chance of distant recurrence, which obviously is not treated by local therapy, increases dramatically. And so the whole concept of adjuvant therapy is to get rid of this micrometastatic disease, assuming we can identify it, which we can't, and then try to cure these patients. Try to cure this neural wedge of patients here. And I think this is the issue. So we have patients that are going to be cured with surgery. We have patients that our adjuvant therapy is not effective in, which is the majority of patients. And then we have this narrow swatch here, which is the patients that will cure by giving chemotherapy. And so this is sometimes a difficult conversation with the patients because we tell them they have a high risk of it coming back, but really our current therapy is pretty lousy, as I'll show you. So the absolute benefit for giving chemotherapy, giving 4 cycles of a platinum doublet, we can debate which platinum doublet we should give, but the absolute benefit's about 5%. It's a little higher for stage 3, maybe up to 8 to 10%. Now the new 2A, the greater than 4 centimeter tumors, benefits probably a little less than 5%. So we're not, with our current therapy, we're really not curing a lot of patients. And so we're treating a lot of patients that are cured already, and we're not curing a lot of patients with the therapy we are giving. Shown here is this kind of analysis from that LACE meta-analysis that as you increase in stage, the hazard ratio increases. That is more beneficial than chemotherapy, but the absolute benefit is not that great for these patients. The other issue that we deal with is the fact that a lot of the studies that this is based on actually go negative if you follow them over time. There are actually only a couple studies that remain positive, and those are with chemotherapies that really no one uses in the United States unless you go to Sloan Kettering. So that's another issue that we deal with. The assumption is that our platinum doublets are all the same, but that's what we base our treatment decisions on. But the long-term data is a little concerning. So we're going to this is just a slide. It's kind of summarizing a large amount of data, but essentially the take-home message here, which I think is important for our next discussion, is that studies have shown that whether you give chemo neoadjuvantly before surgery or adjuvantly after surgery, the outcomes are essentially equivalent. There are some potential benefits to giving neoadjuvant therapy. One, and again, this is debatable whether you care or not, but it may make the surgery easier, but it's usually easier to administer the chemo up front. You do have a chance to see if there's a response with the therapy that you're given, and potentially you could consider changing your therapy, although there is no real, there is no level 1 data on that, but that's something that gives you the opportunity to do. And so as we're going forward, a lot of the studies are being done both in the adjuvant as well as neoadjuvant setting. But the take home is really our current standard is not that great. So practical issues from our perspective. So if it's a node positive, we generally recommend therapy, but we're telling the patient the benefit's about 5 to 10%. If it's node negative but greater than 4 centimeters, that's now the new stage 2A. We all recommend chemotherapy, but again, the absolute benefit is still less than 5%, and we let our patients know that, and look at the patient that we're actually treating with this. And then obviously this concept of visceral pleural invasion in smaller tumors that can sometimes wear decisions, though there's not definitive data in that direction. We generally try to give cisplatin if possible, as opposed to carboplatin. It is a little better. The only evidence-based regimen is a regimen that's not given in the United States, except for maybe Sloan Kettering and a few other places. Maybe Tony knows of a couple others, but there's not many that use cisvinorelbine. It can be toxic and difficult to deliver, but we can get our patients through it. We generally guide our chemotherapy here and other places based on the histology, with the assumption that these doublet combinations are equivalent. So how do we do better? We're not doing great in the adjuvant setting. When you refer your patients, we're not really adding a lot, at least. So what about targeted therapy? So there was a lot of excitement about targeted therapy, that maybe these EGFR mutant patients, maybe we can cure them using this. And so there was initially some kind of disturbing studies out of Canada. One was BR19. And these were patients that were stage 1B, 2, and 3A. And essentially, this was an early study, so halfway through the study, adjuvant chemotherapy became in vogue, and so they said you could get adjuvant chemotherapy. And then after that, you're randomized to a placebo or to gefitinib or Iressa, which was on the US market and then withdrawn and then became the European standard for a number of years. So it was a reasonable drug to be using for this. And what they found is that it didn't benefit the wild-type patients, which we would expect because they don't have that EGFR mutation. And actually, the EGFR mutant patients actually did worse. There was a survival detriment to actually giving targeted therapy. And so there was a lot of concern about this because there were people out there just giving TKIs. There was actually people giving TKIs if you were a never-smoking female. They didn't even bother testing. They're like, okay, we're just going to give this. I had one lady that was on erlotinib for 7 years. I still can't figure out why. But anyway, she tolerated it, which was surprising. So there was a lot of concern that maybe we're hurting these patients, and we could talk about why that was. Another study came along called RADIANT, which was supposed to address this question. Unfortunately, RADIANT was started after the time we knew about EGFR mutations, but there was still thought that EGFR IHC or EGFR FISH positivity was a good surrogate for that, so that's what they used. So again, a larger study, stage 1B through 3A, could get adjuvant therapy, and then they got randomized to erlotinib, which is used to be the first generation US standard, versus placebo. They used the FDA EGFR wild type dose because that's what's been approved, although it was probably a little too high. And they looked at overall survival. And they saw a couple interesting things. One, patients weren't dying more by getting this, but we weren't really doing anything for overall survival. So what you see is the curves separate, and the patients with the EGFR mutant who got disease, who got the EGFR TKI did not progress as quickly, but as soon as you took it out within a year, so you got 2 years of erlotinib, within a year the curves come back together. So essentially this wasn't curing the patients, it was just delaying the evidence of recurrence. Here's the overall survival data. There was another recent study in China where they actually combine it with chemotherapy and essentially saw the same thing where you see, in this case, gefitinib, you see separation of the curves, but as soon as you stop it, the curves come together. So again, giving targeted therapy, at least the targeted therapies we've tried in the adjuvant setting, really just kind of delay recurrence, but aren't changing this disease. Despite this, and because there's been some issues with these other trials, there is a large trial that we have open here, and it's open across the country, called Alchemist. And this is a everyone's a winner trial, as we'll see. So it's stage 1B to 3A who are resected. They get standard adjuvant therapy, whatever that would be, likely a platinum doublet. And if they have an EGFR mutation, they're actually randomizing the patients to erlotinib or placebo. If they have an ALK rearrangement, they're using crizotinib, which is the old standard of care, but still a reasonable standard. And then if you're negative for that, this is part of the everyone is a winner, as we'll get to, you have the option of getting either observation or a year of nivolumab. And we'll talk more about immunotherapy in the adjuvant setting. So this is kind of a large study that's accruing slowly, but because to find these patients in the adjuvant setting is difficult. But this is an option here and at many of other institutions. So this should hopefully answer this question. It actually will answer a couple questions. What's happening with EGFR, what's happening with ALK, and then giving immunotherapy after resection, which I think is an open question, because you can ask if you take the tumor out and you've had an R0 resection, there really shouldn't be much antigens for the tumor, for the immune system to see. And so that's one of the issues facing using this drug in the adjuvant setting. So what about immunotherapy? So immunotherapy is everywhere. This is the most curable setting. Why don't we try it in this setting?
And one thing on the immunotherapy, it's not required to have a percent activity.
No. Well, so PD-L1, and we can also talk about this. PD-L1 essentially is if you look in the second line setting, if it's positive, we'll treat you. If it's negative, we'll treat you. It was better than the alternative. So no, it didn't. So PD-L1 only helps you decide if you want to give, say, monotherapy in the first line setting. Other than that, for a lot of these, some were approved with a PD-L1 marker, some were without. It doesn't seem to make a big difference. Although if you are PD-L1 positive, your chances of responding are higher.
That's what I heard. But in the
if
study,
you're negative,
for me, I'd always get the
right.
titer. It makes sense to me. But
right. If it's higher, you have a better chance. If it's negative, you still may do better.
But it's not that good if it's negative. It's not as good.
No, it's not as good, but it's still better than the alternative.
Okay, so let me ask you. I'm sorry for interrupting,
yeah.
but just so I'm familiar with the trial, you do not have to have a marker status percent to give them the immunotherapy.
They will test it, but you do not have to be positive.
Okay, that's all. Thank you.
Yeah, and in the metastatic setting, nivolumab was approved without the marker.
Yes.
Because it was better than
that was the first
docetaxel.
one. It started that way.
Yeah. And we won't even get it, but small cell, the marker seems to not correlate at all. And well, depends which study you look at. But so what about immunotherapy in the adjuvant setting? So we talked a little bit about Alchemist. So there are a number of trials that are ongoing, some of which are open here. And this is probably not a complete list, both in the adjuvant setting and the neoadjuvant setting. In the early stage, there's been a lot more excitement about the neoadjuvant setting for a couple reasons. One, and we'll talk about some of the data, but you actually have the tumor in place, you have the antigen there. You can also, if you're doing research studies, you can get a biopsy, you can treat someone, and then you have the resection, you can see what it's doing. But inherently, if you have more antigen around, that you may have a better chance of having an immune response. And so this is some data from Pat Ford and a number of others, Sloan Kettering, Hopkins, where they looked at, and this was a small number of patients, just 21 patients, just kind of proof of principle trial where they gave nivolumab twice for 2 weeks prior to resurgery. So they essentially delayed surgery about a month. They gave 2 doses of nivolumab, and then they took them to surgery. And there were some cool things. One, they actually, which was surprising, they actually saw some responses, but you wouldn't expect that quickly with nivolumab alone. They saw stable disease. Only one patient had progressed during that time. All were able to have surgery. The cool thing, though, is when you look at the tumor and you look at path-CR, there was a significant number of patients that had significant pathologic regression of their tumors, as well as infiltration of the tumors now with T cells. In fact, you actually had a number of samples, and that gets to that question, whether they're PD-L1 negative or positive. You had a number of patients who actually had complete pathologic responses, which, again, we don't see with neoadjuvant chemotherapy, or if it does, it's highly unlikely. So there's been a lot of excitement about this. And so we have 2 trials here. The second one I'll talk about is one that Lisa Villeruz and Dr. Zakaria are running. The other one that's open is one that we can use in the community, which is a stage 2B and 3A, where again, patients who are fit for surgery, they've had mediastinal staging, they're stratified based on their histology, they are stratified based on their PD-L1, their region, and they're either getting a platinum doublet, in this case with immunotherapy, which is now the standard of care in the metastatic setting, then surgery, and then pembro alone for about a year. Or they're getting the platinum doublet alone, going to surgery in the platinum. So this is trying to answer this question, can this work in the neoadjuvant setting? We also have a trial through the LCMC3, not 30, which is what Netu and Lisa are running. And again, this is a is a biomarker trial where essentially you get your initial staging, you get 2 cycles of atezolizumab, you then have your surgery, and then your adjuvant therapy, and then again about a year of atezolizumab. And so this is kind of an area of like active research, and although there are adjuvant trials as well, which we have one with the Alchemist, I think there's a lot of excitement that either in the neoadjuvant or adjuvant setting this may have a difference. So I'm going to be wrapping up and finishing in 25 minutes. So these are kind of unanswered questions and future directions. One is, and I think I really haven't addressed, but it's really kind of a key thing, is how do we identify and effectively treatments have minimal residual disease? Again, half these patients, say a stage 2 patient, are not going to have any minimal residual disease. They shouldn't get anything. They could walk out that door and they're going to be fine. So there are a lot of work going on looking at circulating tumor cells, tumor DNA, nothing ready for prime time, but really, I think that's the first thing, is we should figure out who we should actually be treating, and we really have not done that. Second is, does immunotherapy have a role in the adjuvant neoadjuvant setting? I say not yet, but maybe. Targeted therapy, although that's kind of what I do, I'm not so sure it's going to have a role in the adjuvant neoadjuvant setting, maybe for tumor reduction prior to surgery. Are there novel combinations that could improve outcomes? And then even the basic things, how can we make the current therapy that we use better? Can we inhibit DNA repair in other ways? This is an area of active research. Again, in the adjuvant setting, these trials take much longer, and we usually lag behind the metastatic setting by years at a minimum. So, and that's it.
Thank you very much.
No problem.
Question for you. When we look at those curves that remain divergent on TKI inhibitor therapy, say EGFR, but survival really remains the same, and as soon as you stop the drug, you essentially come back to the same curve, if I'm understanding that correctly. Is there a role for maintenance therapy in these patients? And we've talked about that in the past, and
Right.
I know there's data for it as well.
So and this is a question in sarcoma and GIST as well, is that, if 2 years of therapy works and then it comes back together, when about 3 or 5, and that's an open question. Some of these drugs, especially the older ones, 2 years of drug was not easy to tolerate. I mean, again, doses they were using, and but it's a good question. But I think, in GIST we know, for example, that giving imatinib, we used to give it for 2, now we give it for 5, that that may be a way, but it may have to be lifelong maintenance, because it doesn't seem like it's getting rid of these cells, it's just suppressing them. But
Any other questions from the audience?
I'm just curious if you have any thoughts on exosome research and the impact that it has.
so exosome, sorry, you've kind of
If you have any thoughts on exosome related research and
Sarah, can you use the microphone just so we can hear you there?
I was just curious if you had any thoughts on exosome-related research and the impact that might have on lung cancer therapy in the future.
There's actually a fair amount going on. I know here Teresa Whiteside's very interested in that, and she's had some people work with her on head and neck and lung. But you can think about it in several settings. One is it may have a role kind of in the early stage setting if you're able to detect kind of these tumor-associated exomes, these TECs. Is that a measure of kind of minimal residual disease? It's still there. The other thing is that a lot of times these exosomes will carry immunosuppressive signals by themselves, and also they carry mirrors and kind of things that can affect gene expression. So I think it's an interesting area. I think we haven't really done enough on it.
Dr. Timothy Percy, it's very good presentation, especially you focus on the adjuvant treatment for lung cancer. So I want to know what's your opinion. You did talk about the TKI in the adjuvant setting. What's your opinion about the stage 3A? Do you want to use the TKI for this specific subgroup of patient?
So as neoadjuvant or?
No, I'm talking about adjuvant. I know for all the group, TKI did not improve the overall survival.
Right.
But for the stage 3A, I think probably it's beneficial.
Oh.
The first reason is these patients, they will get recurrence pretty soon, probably, I don't know,
So
1
the
year.
resected 3As, right? Not
Yeah,
the ones,
the
okay.
stage 3A. So what's your opinion?
I mean, it's really just, I mean, again, I think there needs to be studies looking at kind of longer-term treatment in these patients. You may just be delaying it. I mean, there's really not a lot of data that it made a difference. It does delay recurrence. So I guess but in terms of, it doesn't really change survival. And then you could just argue if they do recur, you just start the drug. I mean, but it doesn't, since it's not changing survival, the question is, do you want to start the drug after they've gone through chemotherapy, or do you want to wait for those patients that are going to recur to start it as their first-line therapy? I mean, you could argue it might be better to have the patient have a couple-year break in between, since it doesn't change how they do.
Yeah, I understand it, but in terms of the thoracic surgery, you don't want to see the patient get a tumor recurrence like 1
But
year.
it's not. That's the problem. It's not preventing the recurrence. It's just delaying the recurrence.
okay.
So if it prevented the recurrence, I'd be all for it. I mean, I think we all would be.
Another question is, do you use the adjuvant chemotherapy for the patient with like a special type of the adenocarcinoma, like micropapillary or like STATs is positive? Because, we know micropapillary is not good. So
Right,
what do you think?
I still don't generally.
Yeah.
I won't treat it differently based on the
Based on the
histology.
micropapillary? Yeah.
It still has to be the size of the nodes, or maybe visceral pleural evasion if it's close. But if it's a small, like it's a 2 centimeter tumor, I'm not giving adjuvant therapy because,
Yeah.
again, the therapy we have is just not. The other thing, it's not like I'm withholding a highly effective therapy. I mean, that's just the way it. With platinum doublet, it's not really.
Yeah, agree.
Have any of the surgeons in the group operated on a patient after induction immunotherapy? Diego, any comments?
But really difficult. I did about 7-8 cases. I did about 7-8 cases, and all were very difficult, extremely difficult.
Right, most of
Especially
our-
with Pembro.
Right, and this is something we're going to see more and more as surgeons as well. These are going to be the active and beneficial drugs, and if we're going to give them a neoadjuvant setting, at least in the Duke setting, it was required to, at Duke, convert most of their VATs, about 50%, to open operations in order to get through these operations. There is a intense fibrotic response, there's intense pseudo response that you see soon after the operation, and that means that the agent's working. For us, it means there's an intense fibrotic response to the actual agent. I don't know if, Rich, you have any comment, but we're certainly going to have to see these patients and have to work through the best way to resect, whether it's minimally invasive. I think we have to remain minimally invasive as best as possible, but something to consider for us as well.
In JTCVS in January from the Sloan Group, they looked at that induction therapy, and of the cases that were attempted with VATS, you're right, 54% were converted exactly for what you said.
That doesn't mean we don't do it.
Right.
It just means be aware of that. As you're taking these patients to surgery, you may be in for far more of a fibrotic response than you expected, just as far more than I'd say some of the induction chemotherapy cases we see, where you may see no fibrotic response whatsoever. Thank you very much, and thank you, Tim. That was a fantastic review. When we started, that top had 2 or elements on there, you know, EGFR, maybe one or two, but now we've got 35% and about 20, 30 different markers. And we've still got the majority, which we don't know what the active elements are in those tumors. Still a lot of work to do. We've got a lot more.